Good afternoon, everyone. Welcome to the last presentation of our Yale Sleep Medicine Grand Rounds for this fall season. My name is Ritika Thapa. I'm one of the pulmonary critical care and sleep medicine faculties here at Yale. Just some brief announcements before I introduce our today's speaker. Please make sure that you are muted. In order to receive the CME credit for attendance, please see the chat room for instructions. And you need to sign up to get this credit. If you've not signed up already, please send a message to Debbie Lovejoy. And if you think anyone else is interested in joining, please reach out to her as well. And if you have any questions or comments during the presentation, please use the chat room, or you can unmute yourself at the end of the talk and ask the questions, and I will moderate the session. Recorded versions of these lectures will be available on YouTube 2 weeks after the presentation. And here I will introduce our today's speaker. I have the extreme pleasure and honor of introducing Dr. Jason Ackrivo. Dr. Ackrivo received his medical degree from Rutgers University in New Jersey. He then completed his internal medicine residency from Boston University, where he was also the chief medical resident of quality and patient safety. He then completed his pulmonary and critical care medicine fellowship and sleep research fellowship from University of Pennsylvania, where he also completed his Master's of Science in Clinical Epidemiology. He's currently an assistant professor of medicine and neurology at University of Pennsylvania, and is also an associate director of the J. and Randy Fishman Center for Home-Assisted Ventilation at UPenn. His research has primarily focused on neuromuscular disease, chronic respiratory failure with home ventilation and home monitoring, along with transcutaneous CO2 monitoring, and he has received several grants to work on these topics. He's also lectured in courses in these topics regionally and nationally, and has been really advancing work in this field. He's also the founding director of an international virtual didactic discussion of experts and learners based on home ventilation called PEEP's Talking Path, a case-based home ventilation didactic series. I'm also a part of this, and I have to say this is an extremely educational platform for anyone interested in home ventilation. He's also received many awards and has authored many publications. Dr. Ackrivo also holds leadership position in many national societies, as well as on numerous editorial boards. Thank you again so much for being with us, Jason. And without any further delay, I would like to hand it over to you to share your expertise on respiratory care of neuromuscular disease, clinical research in respiratory care of neuromuscular disease. Thank you.
Oh, thank you. That was the nicest introduction I've ever gotten, even though I haven't had too many of those. But thank you. Thank you all for being here, and I appreciate the invitation. I was asked to show this slide for the CME code 47128. And I'll move on to my funding sources, and I have no conflicts with this talk, nothing relevant. And so I wanted to first start off with some actual questions I've gotten from my patients that if you've cared for anybody with neuromuscular disease, you might have gotten similar types of questions. And I found that these questions actually ended up sticking with me because they've helped me direct the direction of our clinical research questions, as you'll see. So questions I've gotten from some people with neuromuscular disease, particularly ones that may be more rapidly progressive, or what will things look like for me 6 months to a year from now? What will the trajectory of my disease be like? How do I know if this machine is working for me, referring to their BiPAP or non-invasive ventilation device? And a patient at an early stage ALS, is there anything I can be doing now to help my breathing? I think that these are all questions that we struggle with. We don't necessarily have terrific answers for, but as you'll see, we're trying to address some of these with the research that we're doing. So I'll discuss with you a brief overview of the timeline of respiratory issues in neuromuscular disease. And then, as I mentioned on the previous slide, I'm going to show you how our research is trying to address some of the major knowledge gaps in respiratory management of neuromuscular disease. So one of the neuromuscular diseases, which it tends to be quite rapidly progressive and so is amenable to shorter term clinical research studies, is amyotrophic lateral sclerosis, or ALS, or sometimes referred to as Lou Gehrig's disease. It's a progressive neurodegenerative disorder, most commonly in adults, that causes motor neuron weakness. It has a very heterogeneous presentation. It can start at almost any muscle in the body. And then beyond the presentation, it has a very heterogeneous and variable rate of progression. Median survival tends to be about 2 to 4 years. However, about 10% live longer than 10 years. And the motor neuron cell death in ALS tends to cause several different deficiencies. So you can have a bulbar weakness, as well as weakness of the diaphragm and accessory respiratory muscles. This can lead to impaired cough and decreased airway clearance, impaired secretion management and swallowing, and then, as I'm sure all of us are familiar with, is hypoventilation. And these all kind of combine to cause these outcomes that we often see either in your clinic or in the inpatient side of pneumonia, diurnal daytime ventilation failure, and chronic hypercapnia. And then the most common cause of death in ALS, as far as we can tell, is respiratory failure. And so if you have, beyond just ALS, almost any neuromuscular condition, you often have this general timeline of onset of symptoms followed by diagnosis. And at some point during the disease, they may develop respiratory symptoms. And often a neurologist is involved quite early, obviously, for making a diagnosis. But then the timing of which to involve a pulmonologist or respiratory trained physician, it tends to be kind of controversial. Should we wait until the time that the person develops respiratory symptoms? Should we try to manage it as well as we can and have the pulmonologist involved later when they need some more advanced therapies? Or knowing that the respiratory symptoms may be coming, should we get a pulmonologist involved earlier? I would argue that you might get a different answer depending on which practitioner or which healthcare center you talk to. And so this kind of controversy has fed into the main themes of my research. And there's really three main themes that we've mostly been focusing on. The first one in the bottom left is the early identification or prediction of when someone might actually start developing respiratory insufficiency in the course of their disease. Beyond that is respiratory monitoring. So how are we monitoring the respiratory function, and how do we know that the therapies that we're using are actually working? And then the third main theme is therapeutic approaches. So can we develop best practices for trying to maximize the therapies that we have to improve quality of life and hopefully survival? So I'll start with the first main theme, which is early identification and prediction. So sticking with the timeline here, if we know we have a disease that goes on to develop respiratory insufficiency and complications, and you're in an academic center where we often are collecting clinical data from the first visit, could we potentially use these baseline factors that are commonly collected in most clinic visits as predictors of whether or not or how soon they would develop respiratory insufficiency down the line? If we could predict this, it may improve physician-patient communication, timeliness of interventions, goals of care discussions, and clinical trial design. So the first study I wanted to share with you is a clinical prediction tool for individuals who may be at high risk of early respiratory failure or respiratory insufficiency in ALS. So this was a retrospective cohort study that we performed using two main data sets. The primary derivation cohort was at the University of Pennsylvania. The entire cohort contains approximately 1,100 patients spanning about 10 years, all seen at the outpatient ALS clinic with standardized visits approximately every 3 months. And then we decided to validate our prediction model in a clinical trial cohort database known as PROACT. It's a phase 2-3 ALS clinical trial database. It has over 10,000 patients in it, at least when I did this study several years ago. It may have more now. It has been completely de-identified and has many overlapping variables with the Penn database. And our primary outcome was a composite outcome of respiratory insufficiency. So having any of the bullet points here qualifying you as having respiratory insufficiency within 6 months from the baseline visit. So that could be initiation of non-invasive ventilation, a forced vital capacity less than 50% predicted, receiving a tracheostomy, and considering the most common cause of death is respiratory failure, we also included death as well. We included subjects that obviously had a diagnosis of ALS. We excluded anybody who had any prior use of mechanical ventilation, a low FVC, or given the 6-month timeline for the outcome, had follow-up of less than 6 months. So we ended up using in the Penn derivation cohort 765 patients, and then the PROACT validation cohort just over 7,000 patients. The baseline characteristics of interest that we could include into our model are the ones shown here. I think many of you are probably familiar with most of these. The one in the middle column called diagnosis delay, that is the time between the patient's perceived onset of symptoms to the time that they are diagnosed. There's also a functional rating scale called the ALS functional rating scale shown in the right column. This is a 12-question a categorical scale that helps measure the person's motor function across various domains. 2 of the 12 questions include dyspnea and orthopnea. So our multivariable logistic regression model was the one we ended up with is the one that's shown here, where we forced age into the model as a confounder, and then the other ones that we found significant are shown here, including the diagnosis delay, symptom onset site, forced vital capacity, the total functional rating scale score, and then the dyspnea score. And so what we ended up doing with that model is categorizing patients into whether we predicted them to be at high risk of developing respiratory insufficiency within 6 months versus low risk. And we considered, we had to choose a cut point. And so we considered anything 45%, probability of 45% or higher as quote unquote high risk, and then lower than that as low risk. The actual outcome prevalence in the 2 databases are shown here. In the Penn cohort, the outcome occurred in 39% of the subjects, and in PROACT was 35% of the subjects. So in this retrospective study, and the derivation cohort, we had pretty high sensitivity, specificity, positive predictive and negative predictive value. And then, not surprisingly, when we externally validated it in another data set, the sensitivity did drop. We still maintain a high specificity, and we had moderate positive and negative predictive value. So, there was some misclassification that did occur, although overall, the model was performing rather well. Shown here on the left, I show the receiver operating characteristic curve and the area under the curves. In the red curve on the leftmost graph is the Penn derivation cohort with an area under the curve of 0.86. And then the blue curve is the PROACT external validation cohort with an area under the curve of 0.74. On the right, I show a Kaplan-Meier curve for the actual time to respiratory insufficiency stratified by your baseline prediction of whether you're going to have that within 6 months. So you can see that based on assigning people by their original prediction, there is an early separation in the curves quite early on in follow-up. But that was all retrospective. What we really want to do is see how well does this perform in a prospective study. So we got NIH, NHLBI, K23 grant funding to perform a multi-center prospective cohort study at the ALS clinics of the centers shown here: University of Pennsylvania, Jefferson, Temple, and Penn State Hershey Medical Center. And I originally called it the Philadelphia ALS cohort study, and then we added on Penn State, so I had to change the P to a Pennsylvania ALS cohort study, or also known as the PAL study. So our target enrollment was 160, and I'm happy to report that a couple months ago, we actually reached our target enrollment, but we still need to follow them up. So we have complete data so far in 115 patients. I've shown the baseline characteristics here, which are pretty much characteristic of and similar to other epidemiological studies that you may see of ALS, particularly in the United States. And of the 115 subjects that we have so far, the model is performing with an area under the curve of 0.80. This is our calibration curve, which shows pretty good performance. It does seem like there's slightly fewer than expected events at the higher predicted probabilities. And this is a Kaplan-Meier curve for this study, where showing the separation in time to respiratory insufficiency. by the original predicted low versus high probability of the event. And so far, I've shown here on the slide the sensitivity and specificity of 72 and 78%, positive predictive value of 67%, and a negative predictive value of 82%. So we definitely still have some patients that we have to complete our data collection and analysis on. This is all unpublished so far. And we hope to further analyze this, hopefully for publication sometime in the first half of next year. So beyond clinical prediction models, we've also been asked by patients, what's my trajectory going to be like? And I've kind of turned that around and thought, okay, are there phenotypes, respiratory phenotypes of patients that we might be able to identify? And so what I ended up doing is taking the same two databases that I mentioned before, the Penn cohort and PROACT cohort, excluded patients who are already on mechanical ventilation. And if we want a trajectory in terms of their data over time, we really have to exclude anybody with less than 2 clinic visits. And what our outcomes were was we decided, since we're collecting a forced vital capacity at every visit, we might be able to map out the change in their forced vital capacity over time and then look at characteristics of differing trajectories. So there is a way to do this. It's a form of latent class modeling known as group-based trajectory modeling. And what this is it's a way to kind of approximate a cloud of different trajectories, of different FVC trajectories over time. And each of the curves serves as its own statistical device for approximating a distribution of patients. Once an individual more or less becomes a member or assigned to the trajectory, it then uses logistic regression to look back at characteristics associated with those trajectories. It's kind of like if you've ever looked at a topographical map. It's a way of approximating and describing what's there, although you know that in real life those lines don't actually exist on the land, but it's used as a way to help describe what you're seeing. So in this study, which we were able to publish in the Blue Journal, we found that there are 3 main groups of patients. The first is a group shown in the green curve that starts with a high FVC and progresses rather slowly over time, and that represented about 14% of the cohort. There's a second group we termed rapid progressors, which started at a high FVC but progressed much more rapidly than the first group, and that was 39% of the cohort. And then there was a third group, which we called stable low, where the FVC was low to begin with and kind of stayed low and progressed not as rapidly over time. And that was about 47% of the cohort. We then tried to externally validate this in the PROACT cohort, and it did externally validate. We also compared the assigned group in the PROACT cohort to their time to respiratory insufficiency. So not just showing that there's similar trajectories of FVC over time, but does it actually have an association with clinical outcomes? And as you can see here, the groups assigned, or the individuals assigned to each group, had a significantly different time to that outcome of respiratory insufficiency that I mentioned earlier, suggesting that these may actually represent different respiratory phenotypes that are progressing at different rates. And we did look at characteristics associated with the different groups, and we found that there were differences in the diagnosis delay, the FVC, the FRSR total scores. There was also differences in BMI and onset site. We did find that the different groups had, according to which aligned with their names and what you would expect with the groups, is a different time, not only to respiratory insufficiency, but to overall both from their initial visit and the symptom onset. So there's definitely a lot more work to be done in this area to try to flush out what these different groups actually are, to maybe combine this with some other additional predictive variables, such as things like their genetic makeup and characteristics. And there's a lot of work being done right now in biobanking and looking at various things you can measure in the blood at baseline. So stay tuned for further refinements of this in the future. So the second main theme is respiratory monitoring. So how are we actually monitoring the respiratory function for these individuals? Really, what we tried to look at is there a way to potentially maximize the benefit of the therapies that we're offering? And I think if you ask different people about the care of patients with neuromuscular disease, what are your goals? It probably boils down to something similar to the three options I show here, which we want to try to maximize quality of life, provide a restful night's sleep, and optimize gas exchange. And specifically on the last point, there is available technology that we could leverage to try to optimize this with the hope that we can try to improve their overall quality of life and potentially survival. And so when we're talking about individuals with neuromuscular disease, really we're talking about chronic respiratory failure. And so when you're thinking about chronic respiratory failure with hypoventilation, we're really heavily concerned with carbon dioxide levels, as I'm sure many of you are aware. But there's different ways to measure carbon dioxide, which can be a bit problematic sometimes in the outpatient setting. So the gold standard is the arterial blood gas, which, as I'm sure as many of you have experienced the outpatient setting, this can be quite burdensome, and it only represents a snapshot in time. You can do inline and tidal CO2 monitoring, but this requires a closed system, so really is only mostly useful for tracheostomies. And then lastly, there's the nasal cannula CO2 sampling, which can be affected by the person's dead space, minute ventilation, if they're a heavy mouth breather. And it can be quite difficult or not compatible with if you're trying to get a CO2 at the same time that they're wearing their non-invasive ventilation mask. So there is an additional way to measure carbon dioxide, and that would be a transcutaneous CO2 monitor. It has the advantages of being painless. It's unaffected by bulbar weakness, which is a common limitation of the usual measurements that we take, such as spirometry. And it does allow you to do spot checks for brief recordings, or you can actually do a more prolonged continuous recording. And how does it work? Well, what you do is you place the sensor on an area of thin skin where the sensor will heat up the surface of the skin. And before you put it on the skin, you put a drop of electrolyte solution. The monitor sits on top of the electrolyte solution and it heats the surface of the skin. And that heat will dilate the capillary beds under the surface of the skin. The capillaries will dilate, and this is for a process called arterializing the capillaries, which actually facilitates gas diffusion to the surface. That gas, including CO2, will rise and affect the pH of the electrolyte solution. And that pH change is converted by the machine to a CO2. These are some of the manufacturer recommended locations for putting the sensors. As shown here, we usually use the ones on the face, so either the forehead, the cheek, or the earlobe. And here is shown the Centec monitors I've shown on a couple of slides. And this is just one example of transcutaneous CO2 monitoring. And I should mention I have no financial relationship with them whatsoever, but we use the Centec monitor at our center. Transcutaneous CO2 has been assessed via meta-analysis and systematic reviews to be compared to arterial blood gases. And it's been found that there's a pretty low mean bias compared to arterial blood gases and a clinically acceptable 95% confidence interval. So how do we use it? We often use it in clinic like an additional vital sign as a brief spot check when they're in clinic, and it can run in the background while you're talking to the patient and doing your history. Another way you could use it is you can actually measure a CO2 in real time as you're adjusting the person's ventilator settings. As shown here, this individual has a nasal mask on and the sensor is on her left earlobe. It's also compatible, obviously, with a full face mask as well. So this is another way that you can potentially use this to help improve the care of your patients, is trying to get a real-time assessment of how the CO2 reacts if you're adjusting the ventilator settings in clinic. And there's a lot of, I've talked about a lot of potential uses for CO2, how it could be beneficial. But how do patients and other clinicians actually feel about using transcutaneous carbon dioxide monitoring? These are stakeholders that need buy-in before you actually successfully implement this. So we actually got a grant from the ALS Association to use in-clinic transcutaneous CO2 monitoring in 2 centers at the University of Pennsylvania and Penn State. And what we wanted to do is really just get the stakeholder input on their experience with using this monitor in the clinic for 15-minute spot checks during a regularly scheduled ALS clinic visit. And after performing the monitoring, we would survey clinicians and patients on their experience. In total, we surveyed 186 patients. And in total, from both centers, we surveyed 14 clinicians at various time points throughout the study. And we found on a Likert scale of 1 being strongly disagree to 5 strongly agree, that patients overall felt very comfortable. They were willing to repeat it at a follow-up visit. They found that carbon dioxide level was meaningful to their health. We did provide a 1-page kind of brief education about what CO2 is during the monitoring session. And they also expressed interest in potentially using the CO2 monitor at home. More on that in a minute. We also surveyed clinicians on their experience, and they found it to be acceptable, feasible. They reported that they trusted the monitor, they found the results useful, and that they addressed a gap in ALS care. We also, kind of from a quality improvement-esque standpoint, wanted to just show, if you're using this in clinic, how likely are you to actually get a value in a reasonable amount of time? And so of the 345 eligible patients during a 1-year study, we were able to actually put the sensor on 90% of them. And of those 309 subjects, 95% of the time we successfully got a CO2 value. Most of the time, the reasons why it did not was because the sensor would fall off the person's skin. For a 15-minute recording, from hands-on in the hallway to recording the patients to back out into the hallway, hands off the machine, it took a median of about 16 minutes. So collecting this data just in case there are other busy clinics that are considering using this. And we feel that this data does suggest that CO2 monitoring is feasible and valued by patients and clinicians, at least in a clinic. Now, the typical ways that we monitor respiratory function in ALS, kind of standard of care, often involve several different tests done, which includes the spirometry for forced vital capacity. It's very reproducible, it has prognostic value, but it can be very limited if the patient has significant bulbar weakness. They also recommend maximal inspiratory pressure. One advantage is that it may fall before the forced vital capacity. But again, it's a difficult maneuver for anybody to do, let alone neuromuscular disease, and also limited by bulbar weakness. And then there is the option to do a nocturnal pulse oximetry. It's very available, easy to use. But again, going back to a few slides ago, we're talking about hypoventilation, carbon dioxide levels. The pulse oximetry tends to be a bit more of a surrogate for hypoventilation. And this is a slide by a clinician out in Stanford, Dr. Michelle Cal, some of you may know her, that highlights the progression of respiratory impairment in neuromuscular disease, starting early on with abnormal gas exchange during sleep, followed by sleep study disturbances, symptoms of sleep disturbances, and only later does the subject actually, or the patient actually, get daytime abnormalities in gas exchange and symptoms. So the purpose of this slide is to just highlight that if we're waiting until there's significant daytime symptoms or issues during the day, we may actually be well behind the true onset of this person's respiratory impairment. So kind of thinking about that and the capabilities of the transcutaneous CO2 monitoring, we realized that the CO2 monitor can actually generate reports with tracings over a prolonged recording. So shown here is a snapshot, or screenshot, I should say, of an overnight report of a patient with ALS who wore the CO2 sensor from about 10 p.m. to 6 a.m. And you can see a simultaneous CO2, oxygen, and heart rate monitoring throughout the period that they're wearing the sensor. So we thought about this and thinking that, okay, if you can actually do this, the patient can wear it while they're sleeping. Is there a way to leverage this to potentially recognize respiratory impairment earlier on than our standard of care daytime measurements? And so this was a small grant that we got from the Muscular Dystrophy Association to do a pilot study of nocturnal transcutaneous carbon dioxide monitoring in the patient's homes. So this is a 2-center study, University of Pennsylvania and Penn State, where we recognized that asking them to go for sleep study may be challenging with the impaired mobility of having ALS, but what if they actually could do it in the home? So our protocol, more or less, was enrolling patients during their regularly scheduled ALS clinic visit. During the day, they would have a forced vital capacity, a MIP. We collect respiratory symptoms, and we would do a daytime CO2 spot check, like I described a few slides ago. We then trained them on how to use the monitor, and they brought it home, set it up, wore it overnight while they slept, and then mailed it back to us. And we repeated it every 3 months for up to a year of follow-up. So again, this was a small pilot study. So it's only 16 subjects. We enrolled subjects with an FVC between 50 and 90% that were not on any respiratory therapies or supplemental oxygen. We had to choose a definition for nocturnal hypercapnia. And if you dive into the literature, it seems like the definition kind of varies from study to study. So we decided to use the one identified by the American Academy of Sleep Medicine, which is a nocturnal CO2 rise of at least 10 millimeters of mercury above the daytime value to a value above 50 for at least 10 minutes. And so in 16 subjects, we found that over 1 year of follow-up, the first column shown here, the nocturnal hypercapnia column, 38% of the subjects developed nocturnal hypercapnia at some point during the follow-up. And all of them developed nocturnal hypercapnia prior to the FVC falling below 50%, or the nocturnal pulse oximetry being abnormal as well. 67% of them had nocturnal hypercapnia before the MIP was abnormal, and all of them had it before daytime hypercapnia occurred. Just for your reference, for the ones who are eukapnic throughout, I show the rates of the various abnormalities in testing shown here. So obviously, this is something that we would like to explore in a larger sample size to really see what the true incidence of this is, and to see how clinically significant this is if you can detect nocturnal hypercapnia earlier than the standard of care measurements. So you might be wondering, okay, all this data about hypercapnia and CO2 possibly being high, why should we care? Well, to try to answer this question, we actually partnered with a group over at the University of Michigan who had a large database of chronic respiratory failure patients who had neuromuscular disease plus other conditions who were seen in their assisted ventilation clinic and were followed for at least 2 years. They included a data set of 337 patients who had hypercapnia at their baseline visit to the clinic. So they got a transcutaneous CO2 every clinic visit, and they were included if their baseline CO2 was above 45. There was a variety of diagnoses in this data set. Over half of them had various types of neuromuscular disease, and then the remainder had about an even spread of COPD, spinal cord injury, and obesity hypoventilation syndrome. And over the 2 years of follow-up, 23% of the subjects died. So our methods here was a multivariable Cox proportional hazards model, where we wanted to look at an outcome of all-cause mortality at 2 years from the initial visit. And to assess the effect of CO2 over time, since we're collecting it at every visit, we used transcutaneous CO2 values as a time-varying covariate. In recognizing that the rate of risk of death could change over time, we actually had time-varying coefficients, with the hazard ratios being assessed between 0 to 6, 6 to 12, and greater than 12 months. We also adjusted for potential confounders, as shown here. And so what we found in this population of subjects who had hypercapnia at baseline, that if you lower their CO2, and even the more you lower their CO2, that this suggests that there's an association with improvement in survival. So as shown here, we bucketed them by the amount of percentage decrease over time. So suggesting that there may be a survival benefit in this retrospective study to lowering a person's CO2 if they're initially hypercapnic. We also looked at absolute values of CO2. So if you could lower or keep your CO2 below 50, there seems to be a survival benefit across all diagnoses. And then we specifically looked at a subgroup of the ALS patients, which there was 56, and it does seem that there was a similar pattern of survival benefit. we found that each 5 millimeter decrease in CO2 was associated with a 33% reduction in the risk of death. So again, retrospective, this was not randomized. There certainly could be a lot of confounding, but begins to suggest that maybe there's a potential survival benefit to improving CO2 in individuals who are chronically hypercapnic. And I've talked a lot about the benefits of transcutaneous CO2, but there's some limitations you should definitely be aware of. First of all, methodological. Given that it has to heat up, it requires a few minutes to stabilize the CO2. It has to constantly be calibrated. And maintenance is a big issue. There's a lot of consumables that you have to regularly replace and stay on top of to keep the machine accurate. And I would encourage anybody that's entertaining using this in their clinic or wherever you work, you need a champion within your group who's going to stay on top of the maintenance. Otherwise, it becomes inaccurate and your group will lose trust in the device. Unfortunately, right now, transcutaneous CO2 is not a billable service. It's not accepted as well as a way to document hypercapnia for NIV qualification. And given the heating mechanism, there may be some factors such as skin hypoperfusion or thickness of the skin that may limit its accuracy. And then last but not least is the cost. The technology is still quite expensive. Hopefully it may come down over time. If we get more research that shows its benefit, potentially it may be reimbursable, which may help ease the burden of that. So the last theme I wanted to cover was therapeutic approaches. So kind of therapies that we have and trying to optimize them for our patients. And I think that, particularly in ALS, there's a good body of evidence suggests that there may be a survival benefit to actually using NIV in ALS. This is actually a slide that I think a few months ago you had Dr. Bethany Lucier come and talk to. I actually took this from her with her permission to show some of the prior research that shows a suggestion and survival benefit for using NIV in ALS. But the ideal management once you're on NIV really is not so clear. A lot of the guidelines focus on when you should start it, but what you should actually do after you're on it or how much you should be using it, maybe not as clear. So some of our research hope to potentially look at how NIV is associated with survival in ALS, and of those on it, is there maybe a minimum dose that is associated with that survival benefit? So what we did is we took the Penn cohort that I mentioned for a couple studies in a few slides ago, and I noticed that in that cohort there were some subjects, for reasons which were not recorded in the data set, were never prescribed non-invasive ventilation, as opposed to the ones who were prescribed at some point in their disease course, at least in their follow-up. So I thought, well, what if we try to compare the two groups? Is there a way to compare a NIV so-called never user versus the NIV users who were ever prescribed non-invasive ventilation? And so what we ended up doing was matching these individuals. So we took folks who, at the time that NIV was prescribed, collect the data at the time, using the data at the date that NIV was prescribed, and then try to use that data to create a matched pair with someone else who never used NIV but has very similar characteristics, and followed them forward in time. So we matched them across several characteristics as shown here, and then followed them forward and assessed their overall survival, and also used the NIV hourly usage as a time-varying covariate for the overall kind of dose effect, if you will, of NIV. And so we found that amongst these matched pairs, that overall NIV use was associated with significant improvement in reducing the risk of death. And we also adjusted for some of the additional confounders as shown here. So suggesting that, at least in this matched pair retrospective study, the NIV use was associated with approximately 26% reduction in the rate of death. And so we also wondered, okay, well, what about of the folks who are using NIV? Is there something about their usage pattern or amount of usage that could be associated with a further improvement in survival? And we found that looking at what I think many of us often use as a recommended minimum quote unquote dosage, if you used it at least 4 hours per day on average, there was a 33% reduction in the risk of death throughout the follow-up period of the hazard ratio of 0.67. And again, this is amongst NIV users who are prescribed NIV, and this was assessed using patient-reported hourly usage. So, definitely it's a retrospective study. We definitely could have several different ways we could have looked at this data, but it does at least suggest that there may be a survival benefit to those who are more adherent to therapy versus those who are prescribed but don't use it as much. So all this is well and good to talk about the potential benefits of respiratory care, but how do patients feel about it? If you have ALS, what is it like as a patient? How do you view the aspect of respiratory care fitting into your life? So another aspect of our K23 grant is performing semi-structured interviews with patients diagnosed with ALS and their caregivers, and just trying to learn from them using their own words as data for what it's like to be a person diagnosed with ALS and how you view respiratory care. Some themes that have come out of this study include acceptance of breathing treatments, whether you're proactive versus reactive with your health, looking at your overall likelihood of starting respiratory care and thresholds for starting. If you were started on respiratory care, such as non-invasive ventilation, what's your experience been so far? And then also another theme that's emerged is the perceived burden of caregivers affecting their choices. And here's some quotes. Again, this is all unpublished, but highlighted here in red, the top two quotes on talking about early non-invasive ventilation. A couple subjects, it'd be useful to have treatment in place when it happens or before it happens. I don't want there to be an emergency when I have to learn it. Second quote here is somebody was worried about the standard every 3 months between clinic visits. So worrying that their symptoms may actually progress significantly in that time point. They, might prefer a little bit closer follow-up. On understanding their approach to their health, one subject said that, I tend to be more proactive, but with a diagnosis like this, I, in their words, put the brakes on. There's only so much I can take at once. And the last quote, I'm not one to just do something because the doctor tells you to. So this is extremely complex, highly variable, wide spectrum of patient perceptions, which suggests that taking a standard, if I may, cookie cutter approach to instituting respiratory care in such a complex disease, we may actually benefit from trying to meet the patients where they're at and trying to personalize an approach. So publish this hopefully sometime next year, start introducing respiratory care for subjects. And then the last part of our K23 grant is a small pilot trial instituting something known as lung volume recruitment. Doesn't seem to be done as much in the United States, although is done quite commonly in other countries, in using a cough assist machine to perform lung volume recruitment. It's kind of like a physical therapy exercise of expanding the chest wall through a more full range of motion. And we're introducing it before insurance will pay for a cough assist machine in just 20 subjects. And we're trying to see what benefit there is to using it that early and gathering the patient experience as well. So stay tuned on that. So I talked about a lot of research that we've done. Where do we go from here? Where does our future work hope to take us? A lot of this centers around potentially, hopefully getting the funding for multi-center studies, randomizing different types of interventions and seeing how it affects outcomes. And at least specifically around the management of NIV, could we be studying different initiation thresholds on that line related to that timing of non-invasive ventilation, talking about different approaches to introducing respiratory care, as I mentioned on the previous slide, and what monitoring strategies we have, and related to that, what biomarkers are there for helping guide our management once they're on respiratory therapy. Realize I'm talking to a group of sleep clinicians. A lot of us are familiar with the data monitoring that we have for the various home ventilators, which now is collected in an online cloud-based web server. And oftentimes we're looking at this data on a one-on-one basis with our patients. But if all this data is being continuously fed through the cloud, and we're collecting, almost minute by minute data on all these patients, well, these companies are sitting on mountains of data. And we might be able to go beyond the one-on-one assessment of the data with our patients and begin to look at this at more of a cohort level. So we can potentially see how patients respond to different types of management strategies and begin to build almost like a registry of ventilator data for patients with chronic respiratory failure, and using that to feed into studying outcomes of different management strategies. So in conclusions, a lot of this I've mentioned already, but the respiratory management of chronic neuromuscular respiratory failure has several knowledge gaps. Clinical prediction tools and phenotyping may identify high event rate populations that may be suitable for clinical trials. We may consider trying to monitor ventilation more, if feasible, rather than static respiratory efforts like spirometry, to enable early recognition of respiratory insufficiency. And rigorous prospective multi-center trials are necessary to hopefully begin studying different monitoring and management strategies to maximize quality of life and survival. I'll just take a minute to thank a lot of people, including your group, for inviting me to be here today. There's a lot of folks I would like to thank in the Penn Home Ventilation team that worked with me and supported me, the various different individuals who have helped me throughout all of this research and collaborated with me, and my funding sources. This is my email in case anybody wants to reach out to me afterwards. And related to the comment earlier about the Peeps Talking PAP group, if you're at all interested in joining it, you can email me and we could put you on the email listserv so you have contact with individuals around the world that are all interested in home ventilation. And we occasionally also have online webinar case conferences for learning as well. So thank you all for being here today. And that's all I have.
Excellent. Thank you so much, Jason, for this really fantastic and pragmatic talk on this really important topic, and sharing, the excellent pioneering and in-depth work that you guys have been doing at Penn. If you guys have any questions, please put it in the chat room, or you can unmute yourself. Just a quick question, and just completing our offline conversations. Not sure you would have the answer to this, given all these reimbursement issues and funding issues, given that we've seen such benefit with TCO2 monitoring for institutions without proper, home-based respiratory care unit support and funding, do you have any suggestion on ways to have the TCO2 monitoring support available both for, initiation and maintenance of the device?
Yeah, I can try to share my screen again if you don't mind. I actually had a slide. You can see my slides now?
Yep.
Okay, 1 second. So again, I have no financial relations, some of our patients, no financial relationship with Centec at all. But one of my colleagues, Sean Hansen-Flashen, did get Centec to agree to this thing called the Early Adopter Program. So this is, if you scan the QR code, you'll actually be able to go into my Google Drive, where I've posted a one-page application and a one-page overview of the program, where you can get access to a Centec monitor, or I think 2 monitors and 2 sensors, as long as you're spending a minimum amount in consumables per year. However, I have heard that, rightfully so, from some centers, that when they try to do this, the consumables end up being quite expensive. So it depends on how much you use the monitor, but keeping the machine well maintained and accurate. If you have a couple different monitors and you're using it regularly on dozens of patients every week, you might be looking at a couple $100 per month in consumables. But at least this early adopter program might be a step towards your center at least getting your hands on the device. And then you might be able to talk to your center to see if there's available funds to hopefully cover the ongoing costs of consumables. If you're interested, I could certainly put you in touch with somebody from Centec. Again, no financial relationship. We just believe in the technology. I realize it's a barrier to getting all this paid for. So I don't have a clear answer that you might be able to apply at all of your centers, but it may be a combination of just realizing the benefit of the technology, talking to your division, and trying to see if they can help you make ends meet if you can get access through the early adopter program.
Great, thank you. We have tons of questions. So starting with Dr.
Okay.
McNally, what instructions do you give to the patient when doing the daytime TCO2 checks, like talking, moving, changing, breathing? Do you notice that their activity makes a noticeable difference?
Most of the patients, given their, at least in this study, it was neuromuscular disease, they were sitting, they had limited mobility and they were sitting in a chair or a wheelchair, and they would just be sitting still. We don't have them walking around the room. It's totally fine for us if they're talking. Just for sake of efficiency, we often have the monitor on their skin, or sorry, the sensor on their skin while we're doing the history. So a common workflow is we'll have a nurse or a respiratory therapist go in the room. The patient gets vitaled and checked into their exam room. The nurse or a respiratory therapist or anyone trained in the device can just wheel the device into the room, put it on their skin, set it up, and have it running in the background. And then I walk in the room and I do my usual history that I would do whether the monitor's in the room or not, and it's running in the background. And you're often talking to the patient for at least 15 minutes. So the monitor, the 15-minute recording is going to finish while you're in the room. So not much in terms of limitations of their activity. We just have them sitting there in a chair answering questions as they normally would. So whether or not there's going to be a clinical difference in their CO2, whether they're talking versus they're not, in my opinion, maybe a bit biased, I don't think it's going to significantly change their CO2 too much. But they're not mobile during these assessments.
Great, thank you. Next question is by Dr. Ian Weir. Great talk. As a pulmonary and sleep doctor, I see benefit and little risk of starting NIB in all ALS patients at the time of diagnosis. Data suggests NIB may reduce mortality and delay tracheostomy. Is anyone looking at starting NIB as soon as possible compared to waiting for respiratory failure or PFT changes in a clinical trial that you know
of? I'm happy to talk offline on that. We have a grant under consideration that may get funded. But since there's no official notice of the award yet, I don't want to say too much. But yes, we are trying to do that.
Great. Thank you. More to come soon on that.
Yeah, stay tuned.
Next question is by Dr. Parvati Singh. Thank you. Some questions here. Sorry if you already answered. Number one, when would you not trust the TCO2 numbers from an overnight study? Number two, how often would you correlate the TCO2 level with a blood gas or bicarbonate level? And number three, are there any signs in a sleep study that providers should look at for and be concerned for possible ALS?
Wow. Okay. So the
Do you
first
want
one
me
I
to?
think is inaccuracy overnight. So some of the issues we ran into is just the sensor falling off the skin. So you just have to make sure that when you train the patient, you're just very clear on proper placement of the sensor. Now, I think if you have a clinically trained person that's available to help with the setup and train the patient in the home, that may, in my experience, anecdotally, that improves the quality of the data. So, for example, either in a sleep lab, obviously they're attended at the time, but we've also had DME companies bring the device to the home and teach the patient in the home how to do it. And I think that the quality of data from that, it tends to be much better than just asking the patients to do it themselves. Some signs that I would not trust it. So when the sensor falls off the skin, there's just a drop off in the tracing, like tracing just stops. So that would be something where potentially, at least the data around when the sensor falls off and goes back on might not be as accurate given the heating mechanism of the monitor. There sometimes we noticed artifacts sometimes where the CO2 would shoot up to a non-physiological range. briefly, and then it would go back down. We think that that's actually the patient actually, say if it's on their cheek, they roll onto their cheek, and then that ends up putting pressure on the sensor. So that would happen sometimes, but the biggest one really is just the sensor falling off the skin. So we had a strict, for the study that I mentioned where we did the overnight studies, we had a very strict criteria for, number one, the duration of the recording had to be at least 4 hours. Number two, the CO2 had to be calibrated. So there's this phenomenon of a prolonged CO2 recording. You get this CO2 drift over time. If you calibrate the machine before you turn it off, it will correct for the drift and actually produce a second calibrated CO2 line on the report. And so that is a way to adjust for the CO2 drift over time. So if you see that CO2 drift, then I'm much more likely to believe the data. So I feel like I'm just only answered one of the,
and I think
or
she
tried to
also,
answer one of the questions.
and I think she also meant the CO2 numbers from the overnight sleep study, when they're quite monitored. I think, would you say that's quite reliable? Just from an overnight sleep study when we use the TCO2 monitor, not at home.
In the sleep lab,
Yeah.
if it's a transcutaneous monitor, and again, if you're correcting for CO2 drift, I always ask myself if it clinically makes sense with what I would expect with the patient. And in our experience, most of the time it does. Every once in a while, sometimes if you get someone that, maybe they put a drop of the electrolyte liquid, and if there's a lot of bubbles in the electrolyte liquid, well, sometimes that can potentially affect the accuracy. So I would always just ask myself if clinically this makes sense based on the values that you're seeing. So most of the time, again, I may be biased, but most of the time it does seem to make clinical sense. And so I do believe it.
Yeah, I agree. I think unless it's very extreme. The second question is, how often would you correlate the TCO2 level with a blood gas or bicarbonate level?
So, maybe we should for a study. The one of the citations I put in one of my slides, I'm happy to share. There was a Conway et al. Article. I think it was 2019. I'm blanking on the journal, but they did a large meta-analysis and systematic review of transcutaneous CO2 versus arterial blood gases. So I think as long as these are clinically stable patients that are not in a hypoperfused state, and they don't have rapidly changing minute ventilations, this is relative. We feel it's pretty accurate. Ever since we started doing this, using the transcutaneous CO2 in our clinic about 7 years ago or so, I'm struggling to remember a time I needed to send somebody down for a blood gas to clarify. With correlating to the serum bicarb, well, we just, I don't routinely check the serum bicarb. When I'm teaching residents and med students in the ICU, I usually use the chronic respiratory acidosis 4 for 10 rule, or a chronic elevation of the PCO2. Every 10 that it goes up, it will raise the serum bicarb by 4. But I'm not routinely checking it, so I feel like I don't have a great answer for the comparison, but it may make an interesting study as a way to potentially have a more accessible, low-cost way of checking their CO2 when realizing the transcutaneous CO2 can be quite expensive.
And I think the last question she had was, any signs on a sleep study that patient providers should look out for concern for possible ALS, nocturnal hypoventilation?
So we're not routinely doing the sleep studies. I think that there was a group in Germany. I think the last name is Boentert, Boentert, where you looked at, I think it was a large retrospective study of 200 something patients. And he found that there was a kind of various different signs of sleep disordered breathing and ALS, which obviously could be affected by many factors since it's such a heterogeneous disease. Their baseline BMI. I would say that it's certainly possible that REM-related hypoventilation can occur early on, even before the FVC is low, and so that could be detected using transcutaneous CO2 and also pulse oximetry as well. I don't know if there's any specific signatures. I think that we would also need a large study looking at kind of longitudinal nocturnal assessments in patients with ALS and seeing, what are some of the earliest signs and how it progresses over time. And we might be able to begin to look at more or less phenotypes or markers of somebody who maybe have more rapid progression. So, would love to do a study like that too.
Yeah. So I guess for now it's mostly hypoventilation.
Yeah. Sorry, it was a long-winded answer to a question. I don't have a great answer because we just don't do too many sleep studies at our center in early ALS. But it may be interesting to do something more prospective like that.
Thank you. Any other questions? I don't see any. Anyone has any question, please feel free to unmute yourselves.
Hey, Jason, it's Finbar. How's it going?
Hey, good to see you. Thanks for joining.
A quick question. So a number of centers are tending to go more through the DME provider for providing equipment, mask fit, adjustments, titrations, et cetera. From what I gather in your clinic, you're doing a lot of the adjustments kind of yourself face-to-face. Do you feel that for a successful home ventilation clinic, it's necessary to kind of have that infrastructure, or is working through the DME company something that's kind of been relatively successful for you, or kind of what's your experience there?
We're fortunate enough in our area to have multiple DME companies to choose from. So I realize that may not be the case everywhere in the United States. They might have one or two. So we have found the DME companies that we like working with the most because they tend to be very responsive. They understand our work patterns, what we expect. We feel like the patients get good service. So the first step is, I think, is just finding a DME company that you work well with, you have a good working relationship with them, and you feel like they don't mind going above and beyond for your patients, beyond just dropping off equipment. Secondly, I realized that even within the DME company you may like, not all respiratory therapists are created equal. So, with the ventilators, with that bundled payment, you get a respiratory therapist who can go out to the home. But if it's a simpler RAD or BiPAP machine, whatever you want to call it, those payments don't necessarily include a respiratory therapist. So you might not have a respiratory therapist available if you're trying to work with a RAD. I have had DME companies who are willing to accept orders from me with ranges of the settings. So I'll say adjust inspiratory time between X and Y to patient comfort. And so if it's a new start and for whatever reason I'm not able to do it in clinic, I may use that tactic where it's a DME company I know and trust. They understand to be able to work with the ranges of the settings, and they're okay accepting that as an order. You might be able to do that and have them adjust it at home to the patient's comfort. Although I do feel like there is a lot of value with having them come into the clinic for a dedicated ventilator titration session. So, you're using that time in clinic. This is assuming if it's a follow-up visit, you're not doing, family history and talking about all kinds of various things. So you're using that time wisely to just do the ventilator titration in clinic. And I find that there's value in real time kind of going through the various stages of the breath and slowly adjusting the settings while they're wearing the device in clinic in front of you, preferably if they can laying down, but realize that's not always possible. So I am biased towards the in-clinic vent titration session, recognizing That is time consuming. But usually we have it as a follow-up visit. They know they're coming in just for the titration. Yeah, I mean, in 20 minutes, you can actually make up a lot of ground. The only limitation to that is they're awake while you're titrating it. So, their compliance and the respiratory efforts are going to change when they fall asleep. So I do a combination of things. I tend to often have the patients bring in their equipment to clinic to do these types of adjustments. But you possibly could get away with it having a DME doing some adjustments for you if they're willing to accept a range on the settings. You would just have to ask your local DME representative, if I put in, titrate IPAP min between X and Y to patient comfort, and then make IPAP max, 8 above whatever IPAP min is chosen. Like I've done that, and they've actually been able to go with that. So I would talk to them about what their capabilities are and trying to work within, what they're comfortable doing. So I don't know if that answers your question, though.
No, thank you. Great talk.
And Jason, is that billable, the in-clinic vent titration, is that a billable service, or you just do it as a follow-up?
It's just a follow-up visit. Yeah, it's a labor of love. I think that there's in Pittsburgh, I remember Jen Newart and Pat Strollo talking about this concept of a PAP nap. But I don't know if they're actually have a way of billing that. So it's really just, they're coming in, their dedicated follow-up visit time slot, and it's communicated ahead of time. Bring in your equipment. We're going to adjust your settings. So, they just get started right away. So you could, if it goes beyond, so there are billing codes for prolonged care time. I think it's for each additional 15 minutes beyond a certain amount of time. So I think it's G2212. There's these levels at which you can add on billing codes for prolonged care, but you have to exceed a certain time threshold before you can begin using that. So I would work with your local, I guess, billing department on how that would work at your institution. But we have used prolonged care for, some of the visits end up going very long. You can use G2212 for prolonged care. There is a billing code for remote telemonitoring. Reviewing physiologic data. So there's one for that as well. This is actually we wrote a paper 2021 in the White Journal called telemonitoring narrative review, something like that. And in that study, or in that review, there's a table of billing codes that you could review. It's just the only new one is the G2212, which I think was in the last couple of years.
Got it. And then the initial follow-up, if it's 20 minutes, then you just bill it as a regular follow-up.
Yeah. So I realize this is time consuming. We do the best we can to try to stay within the limits, and try to be as efficient as possible.
Great. It's 3:10. Thank you so much, everyone.
Yeah, I'm sorry if I'm making this
Thank you
go
so
long.
much, Jason. No, thank you so much for answering all the questions. It was an excellent presentation. Thank you for accepting the invitation. And thank you, everyone, for joining. Happy holidays to everyone. See you all in January. Thank you, Jason, once again.
Yeah, thanks for the invitation, and happy holidays to everybody.
Thank you. Bye-bye.